This is Meredith Davis, Doctor of Nursing Practice Candidate, and I will be discussing my doctoral project, Improving Outcomes for Patients Presenting to the Emergency Department with Chest Pain Through Rapid Physician Evaluation and Triage, a Quality Improvement Initiative. Chest pain is one of the most common reasons patients present to the emergency department. In 2005, more than 1.6 million patients were hospitalized in the United States with acute coronary syndrome, which includes the diagnosis of acute myocardial infarction. Patients experiencing an acute myocardial infarction often delay seeking treatment for an average of 2 hours after onset of symptoms, while the majority of patients experiencing an acute myocardial infarction arrive to the emergency department by ambulance and are often directly placed in a room. 40% of patients enter through triage. Current guidelines recommend patients presenting to the emergency department with chest pain receive an electrocardiogram within 10 minutes of arrival. Unfortunately, many patients do not receive timely electrocardiograms or healthcare provider evaluation due to increased length of stay and overcrowding caused by issues such as patient acuity, turnaround times of laboratory tests, and diagnostic imaging. A correlation exists between emergency department overcrowding and adverse cardiovascular outcomes for patients presenting with chest pain. Adverse outcomes include death, cardiac arrest, arrhythmias, congestive heart failure, and hypotension. Implementation processes in which patients are evaluated by a healthcare provider in triage have led to improvement in outcomes such as a decrease in wait times, decrease in overall length of stay, and reduction in rate of left without being seen. The goal of this quality improvement initiative was to improve patient outcomes by decreasing the time from emergency department arrival to healthcare provider evaluation and emergency department overall length of stay. A clinical question was formed for this project and is as follows. For adult patients presenting to the emergency department with chest pain, does healthcare provider evaluation in triage affect outcomes such as time from arrival to healthcare provider and emergency department overall length of stay as compared to standard triage processes and bedside evaluation by a healthcare provider? Patients presenting to the emergency department through the triage system with the chief complaint of chest pain were chosen to participate in this quality improvement initiative. Individuals over the age of 30 were included. Individuals who met the stated criteria, who underwent rapid evaluation in triage, and whose orders included a troponin, met the final inclusion criteria. The setting of this quality improvement initiative was the emergency department at University Health Shreveport, a Level 1 trauma center in Shreveport, Louisiana. The emergency department consists of 3 triage rooms, 28 treatment rooms, 4 trauma bays, 15 fast-track rooms, and a psychiatric crisis unit. The current emergency department triage process utilizes 2 of the 3 triage rooms. This project took place in the 3rd triage room, which was utilized as the chest pain evaluation room. 2 tools were selected to be included to measure effectiveness of the training component and effectiveness of the overall quality improvement project. These tools were surveys given to emergency department employees based on a Likert scale format. This is the process map used for the intervention of the project. This quality improvement initiative focused on rapid evaluation of patients presenting to the emergency department with the chief complaint of chest pain. All included staff were trained in the 2 weeks prior to implementation of the project during normal working hours. Staff included registered nurses, physicians, electrocardiogram technicians, and registration staff. The implementation took place over a 10-week period. During this 10-week period, the project took place 24 hours a day, 7 days a week. The project was implemented as follows and is defined in this process map. Upon arrival to the emergency department, patients signed in at the front desk with the registration clerk. The registration clerk then notified the triage nurse of patient arrival, and either the registration clerk or the triage nurse paged for the electrocardiogram technician to complete an electrocardiogram on any patient over the age of 30 with a chief complaint of chest pain. The patient was then taken to the chest pain evaluation room. The electrocardiogram was to be completed as soon as possible with a goal of 10 minutes from arrival to the emergency department. Once the electrocardiogram was completed, the triage nurse notified an emergency department healthcare provider of the arrival of a chest pain patient and provided the completed electrocardiogram. The healthcare provider then completed a brief examination of the patient in the chest pain evaluation room and determined what diagnostic testing needed to be completed. At that time, if an emergency department room was available, the patient was taken to the room where testing could be completed and further evaluation take place. If an emergency department room was unavailable, the patient underwent testing in the chest pain evaluation room and returned to the waiting room until an emergency department room was available. Pre-intervention data was collected and reviewed during the implementation of the project with assistance of the Data Analysis Department of University Health Shreveport. Post-intervention data was reviewed continuously throughout the implementation period and in the 2 weeks following completion of the Quality Improvement Initiative through chart reviews. Staff evaluation of training and the Quality Improvement Initiative were obtained following the training and implementation periods by survey. The effectiveness of the project was determined based on the outcomes identified in the PICO question. Outcomes measured included time from emergency department arrival to healthcare provider contact and time from emergency department overall length of stay. For the post-intervention data, arrival to electrocardiogram time was also obtained. Data was analyzed using retrospective chart reviews, Shapiro-Wilk normality tests, and single sample t-tests with the assistance of the Department of Computer Science of Louisiana State University Shreveport. A total of 20 participants were included in this Quality Improvement Initiative. Pre-intervention data included 780 patients who presented to the emergency department with the chief complaint of chest pain from January 1, 2015 through March 31, 2015. Prior to intervention, the mean emergency department arrival to healthcare provider evaluation time was 100 minutes. The mean emergency department overall length of stay was 411 minutes. Door to electrocardiogram time for participants was 18 minutes. Rapid healthcare provider evaluation in triage decreased emergency department arrival to healthcare provider evaluation time from 100 to 31 minutes. Emergency department overall length of stay decreased from 411 to 345 minutes. Both decreases in time were shown to be statistically significant changes and indicate that rapid healthcare provider evaluation in triage of chest pain patients improves emergency department arrival to healthcare provider evaluation time and emergency department overall length of stay. No adverse events or effects of implementation were identified. Results of this Quality Improvement Initiative are consistent with a review of current literature. Current literature reports that healthcare provider evaluation in triage leads to improvement in patient outcomes, decrease in wait times, decrease in overall length of stay, and reduction in rate of left without being seen. Treatment of patients with chest pain in triage has been shown to be safe and efficient, with few noted adverse effects and proper diagnosis of cardiac conditions when compared to patients receiving bedside healthcare provider evaluation only. Implementing a quality improvement initiative in which patients who present to the emergency department with chest pain receive a rapid electrocardiogram and triage evaluation by a healthcare provider can improve outcomes and decrease time from arrival to healthcare provider evaluation and emergency department overall length of stay. This quality improvement initiative made a positive impact on participants as well as other patients who benefited from decreases in emergency department overall length of stay. Further research should be completed involving rapid healthcare provider evaluation and triage for patients presenting with other various complaints in order to determine effectiveness. Thank you for reviewing this quality improvement initiative entitled Improving Outcomes for Patients Presenting to the Emergency Department with Chest Pain Through Rapid Physician Evaluation and Triage.